Good afternoon, everyone, and thank you for joining this session. My name is Jeff DeShaco. The session is entitled The Drugs and Diagnostic Pipelines, and actually we have both a hybrid of company and academic presenters. So first of all, I'd like to thank Patrick Marcellin for the invitation to participate in this meeting. And secondly, I'd like to introduce my co-chair, Raymond Shinazi. Raymond is a household name. There's none more suitable to co-chair this session with me. He's an organic medicinal chemist by training who has had vast experience and indeed inventiveness in the development of antiviral drugs, which have played a major role in the persistent viral infections in which this audience is interested. So without further ado, I'm just going to indicate that each presentation will be 10 minutes and we'll have a brief 5 minutes for discussion. Please post your questions. I'd like to introduce the first speaker, who is Dr. Ralph Coman. Dr. Coman is the Chief Business Officer for Humedics based in Berlin, but he's a virologist by training, and he's going to introduce the LIMAX test in liver diagnostics to us. Over to you. Thank you, Dr. Coman.
So good morning. I'm from the company Humedics from Berlin and want to introduce the LIMAX test to you. The LIMAX test is a liver maximum capacity test and has been developed between the Charité and the Free University of Berlin. So I want to show you the measuring principle and also some scientific or clinical data that has been done with the test. So the setup and principle. So the liver maximum capacity test, or short LIMAX, is a non-invasive and quantitative bedside test that measures the current metabolic capacity of the liver in real time. So what you do is you have a patient lying in bed, then an intravenous injection of 13C marked metastatin is given to the patient. This is flooding the liver, and in the liver, it is exclusively metabolized by CYP1A2, and the metabolization products are paracetamol and 13C marked CO2, which is exhaled via a mask and via a tube, and goes into a detection machine, which is the flip device. And in this flip device with the infrared laser technology, the 13C and 12CO2 is distinguished. This is with high accuracy in the range of 10 parts per billion. So you get in the end a result in milligram per kilogram and hour body weight, and the test duration, depending on the liver capacity, in a good liver 15 minutes, in a more worse liver 40 minutes. And then with these results, you can, for example, predict liver function after a liver surgery. Now, having said this, if we go to some data, the LIMAX in surgery, this study has been done in 148 patients and is the approval study for LIMAX. And in short words, or as take-home message, in this study it came out that in the results were that patients stayed less days on ICU when they had a LIMAX. They stayed less days in the hospital. They had a reduction in complications, and there were cost savings. And as an example, the threshold here is 150, a LIMAX of 150. So patients with a LIMAX of 150 after the operation could go directly to a normal ward, and there were no complications at all. And this helps, of course, to risk stratify patients in surgery situations. And also in transplantations, studies were done. Here, one study in 99 patients with the aim to early diagnose imminent graft failure. And here you can see that in the end only LIMAX was an independent predictor of graft failure in a multivariate analysis. And the threshold here, or the cutoff value, was 64, a LIMAX of 64. So below this value, it was very likely that patients got an acute, not acute liver failure, but the graft did not work properly, and they need to be set on the retransplant list. So if we move on, so there are also data in other indications, but just to conclude here, you can read yourself. In the end, there are a couple of advantages if you do a LIMAX in surgery and also in transplantation, as I showed in the previous slides. So if we move on to other interventions like TIPS, TACE, and radioembolization, also here a study was done in TIPS, a small one-center study, indeed 30 patients. But you see here that LIMAX before TIPS and after TIPS, there are clear cutoff values of 205 and 165 after the TIPS intervention, and they showed, these cutoffs showed the highest accuracy in prediction of transplant-free survival after TIPS. So also in TIPS, there is a place for LIMAX, and same in TACE. Also here, TACE, a small study, 25 participants, that has been done at the University of Mainz. And in summary here, both baseline and longitudinal LIMAX values are associated with overall surveillance in TACE-treated HCC patients. And the relative change in LIMAX values after the first TACE predicts short-term mortality and may assist in identifying patients who will not benefit from further TACE treatment. This is, of course, very important for repetitive TACE interventions. And just recently, there was a study published with LIMAX prior to radio embolization for hepatocellular carcinomas as an additional tool for patient selection in patients with liver cirrhosis. And if you look on the changes in Child-Pugh situation, this is then the LIMAX is independent from this. So patients with low LIMAX values despite Child-Pugh A situation at baseline have a substantial risk, increased risk for hepatic decompensation after radioembolization. So also here, LIMAX can be used as an additional tool to identify patients at high risk of post-interventional hepatic failure. And so these are the intervention. And last but not least, I want to show one study in liver diagnostic, in this case, a combination of LIMAX and FibroScan, and meanwhile established as a so-called Essen algorithm, because the study was done by Professor Gerken and co-workers like Professor Bichter in Essen. And what you can see here, that these diagnostic tools do not preclude each other. They are complementary. And you can see if you do a FibroScan in patients who you suspect having a cirrhosis or a fibrosis, and you have a FibroScan of lower than 15 kilopascal, there is no cirrhosis, and it's above 40, then it's for sure cirrhosis. But all the gray zone between these two values are a bit difficult to diagnose. And if you do a LIMAX here in addition, then you have a very accurate distinguishing between fibrosis and cirrhosis. And therefore, this combination especially can probably compensate some biopsies, and therefore could be substitute some biopsies. That's what I want to say. So in the end, I come to the conclusion. Having shown you the principle and the data, you now see LIMAX is an innovative CE certified and non-invasive dynamic semi-quantitative liver function test, and has 100% reproducibility. Bedside test, that's all I said, and has proven benefits in liver surgery and transplantation, as well as in other interventions like tip stays or radioembolization, and it can also play a role in biopsy-free differentiation of fibrosis and cirrhosis. So in this sense, the LIMAX test embodies a procedure with high potential benefits for diagnostic reliability, therapy decision-making, course of therapy, and patient safety and satisfaction. So thank you very much.
Thank you very much, Dr. Conan, for that interesting and novel presentation. I hope I've got the right screen up, but I don't see any questions, so perhaps I could start off. You did mention its utility in predicting survival after a TIPS. That's a different measure from predicting the utility of TIPS and the risk of a TIPS, particularly in encephalopathy. And I wondered whether you had, or investigators had the chance to correlate the LIMAX test with the risk of encephalopathy, hepatic encephalopathy, indicative of shunting post-TIPS or not. That would be different from survival, but clearly something you'd like to rule out before doing a TIPS.
Yeah, actually, I don't think that this has been done in this particular study.
Okay. Raymond?
I have a question. So let me ask you, is this LIMAX test also available for adults and children, or is just for adults? Or...
Well, actually, the approval situation is for adults, but there are already some data in children. But the official approval, of course, is in adults. But it's not the technology, but it's always the drug approval that makes this problem, I would say, because actually metastatin needs or needed a complete drug approval, as it is a prodrug of paracetamol. Yeah.
We have Mike Shulsky on, who's posted in the chat indicating that I think you're saying the risk of encephalopathy would be dependent on how much they change the gradient with each tip. Would you like to elaborate on that, Mike, just as part of this discussion?
No, I think it was a great question for Rolf. If it could indeed predict encephalopathy, but each TIPS is individualized nowadays.
Yeah.
So it becomes, I think, challenging to know how wide they would open it. But I would like to ask a second question. I know there was another testing in the past where the substrate was administered orally. Have you compared the oral versus the IV administration?
Actually, yes. So that was, in fact, it was the reason why Charité and the University of Berlin developed this IV formulation or this IV test, because there are some problems with the oral application because of the passage through stomach and duodenum and arrival actually at the liver. And so the data with the oral formulation were not that concludent as they are with the IV formulation, where you can circumvent these problems.
Is the metabolism of this drug instantaneous once you inject it, and the CO2 coming out is just one big burst or several bursts, or how long do you follow?
Well, actually, what you do...
How long do you collect the CO2?
Yeah, of course. Yeah, well, actually, it's like, so inject your drug, it floods the liver, and the metabolism starts spontaneously. And what you are interested in is the peak of the curve. So it's a peak kinetic, and so the deviation over the baseline, and that is something perhaps I need to explain a little bit as well, because we have certain CO2, of course, naturally in the air. So you need to measure a baseline. And then when you inject, then you have a spontaneous peak, and this reflects actually the metabolic function of the hepatocytes.
Okay, I get it. All right.
Yeah.
Thank you.
Dr. Koenen, since there are no questions I can see in the chat, perhaps I can ask you another question. I was going to ask you about how it compares with transient elastography, which strictly is measuring a surrogate of hepatic fibrosis, liver stiffness. And in the study that you quoted from Buchler et al., the ranges that you gave of transient elastography of greater than 40 kilopascals and less than 15 are really very wide.
Yeah.
What we really need to do, and we don't achieve this with transient elastography, is measure gradations and progressing fibrosis from minimal fibrosis to cirrhosis. And in fact, the test is better at ruling out cirrhosis and ruling it in because of the overlap. So I think with those very wide ranges that was done in the Buchler study, it's not a particularly good comparison of measuring hepatic fibrosis or ruling in or ruling out cirrhosis compared to transient elastography. Those greater than 40 and less than 15 is just, in my book, perhaps a very wide range of values for elastography. You need to have a bit more granularity there, is the point I'm making.
Yeah, I agree on the one hand side. On the other hand side, they're clearly in this range between 15 and 40. If you look into the literature, so the correlation, for example, to Child-Pugh or other, let's say, scores are very, I would say they're not very accurate. So therefore, what the study wanted to show is that if you do the LIMAX in addition, you just can better distinguish between FIB stages. So that was the purpose. Yeah.
There is a question from Mustafa Benazouz, who's asked, what about the LIMAX correlation with the child and the MELT score before surgery?
Yeah, actually, if you compare this, there's a clear correlation between LIMAX and all the scores, like Child-Pugh, like MELT score. But if you look at the one independent predictor, for example, regarding risk stratification for liver failure, then if you look at the AROC values, for example, the LIMAX test by far is superior also to compared to these kind of scores.
I think we need to move on. So I will thank you very much for answering all the questions. We appreciate it. And we're just going to move on to the next speaker. Thank you. Thank you.
Thank you.
The next speaker is from Orphalan, and it's Michael Schilsky. And the title is A New Standard for Endpoint for Therapeutic Trials in Wilson's Disease by Available or Non-Ceruloplasmin-Bound Copper. So go ahead, Michael.
Hi, my name is Mike Schilsky. I'm professor of medicine and surgery at Yale University School of Medicine, and I'm going to talk to you today about a new standard for endpoints for therapeutic trials in Wilson disease, bioavailable or non-ceruloplasmin-bound copper. These are my disclosures. This is a cartoon of a schematic relationship between non-ceruloplasmin copper, ceruloplasmin, and 24-hour urine copper. Shown above the x-axis are the values for the serum copper, and below the x-axis are urine copper. In the normal individuals, 90% of our serum copper is bound to ceruloplasmin, and approximately 10, at most 20% is bound to other proteins and peptides, mostly albumin in the circulation. And the amount of urine copper is a relatively minor amount compared to biliary copper excretion when copper is present in excess in our diets. In patients with Wilson disease, where there is difficulty in excreting copper out the biliary pathway, copper accumulates in the liver, and what we see is an expansion of the non-ceruloplasmin copper pools shown in green relative to the smaller amount of ceruloplasmin copper that's present because of the lower amount of ceruloplasmin present in the vast majority of patients. And the expansion of the non-ceruloplasmin copper pool leads to increased urinary copper excretion, shown below the line as an increase here. In patients treated with chelation therapy, we notice a reduction in the non-ceruloplasmin copper, which is our goal. So we have reduction in the tissue copper ultimately. And then we usually don't impact the ceruloplasmin copper too much, but we increase urinary copper as the way of getting copper out of the body. In patients treated with zinc, our goal is to again achieve the same reduction in non-ceruloplasmin copper, but here we might see a reduction in the urine copper excretion, as this does not directly cause that, it blocks copper uptake. When we look at non-ceruloplasmin copper, we have to consider its components and how we've measured it in the past. We have done usually an estimation of the non-ceruloplasmin copper as the fraction that can be subtracted from the total serum copper, which is the copper bound to ceruloplasmin, which we've made a guesstimate of 3.14 times the ceruloplasmin concentration in milligrams per deciliter, and this accounts for the approximate 6 copper atoms per molecule of ceruloplasmin. We also have looked at it in different manner using residual filtered copper with molecular weight cutoffs that tries to separate the ceruloplasmin, which is a higher molecular weight than albumin. And another method uses the exchangeable copper or the non-EDTA bound copper that remains after you pull the copper in from other weaker binding molecules such as albumin, and then you leave only what's left bound to ceruloplasmin, and you can separate the two pools. Now, there are issues with the estimation of the non-ceruloplasmin copper. The problem one is that we look at total immunologic, which contains both the protein ceruloplasmin with its full complement of copper, and some also which is without what we call apoceruloplasmin. So the total number of copper atoms per the amount of ceruloplasmin present may not be accurate. And indeed, when you use that formula, you come up with sometimes 40 to 50% of patients either have 0 or negative values, which is not possible. Other methods have been used, in particular in France. There's been large use of the exchangeable copper method. This has not been necessarily approved by regulatory agencies, but there are reference ranges that have been published and have been utilized locally to provide guidance for treatment decisions. There's also a variation of this where the exchangeable copper is divided by the total serum copper, and here you can see it may be more useful for diagnosis of Wilson disease. However, in the study I'm going to present to you, you can see that there were some inaccuracies which we found within the exchangeable copper, so therefore we needed a different method to use it, and therefore we came upon what's called the non-ceruloplasmin copper by speciation. In this assay, the serum proteins were speciated or separated on anion exchange chromatography, and the peaks were measured for the amount of copper it recovers very accurately, the total copper in the circulation. You can then separate the ceruloplasmin copper in this peak shown here in a normal individual and a Wilson's patient where this is lower. The amount of copper is typically lower, and you can separate that, and you can then subtract that from the total serum copper, both very accurate measurements, and come up with the new NCC speciated. Let me introduce you to the chelate study now. This was the first randomized prospective trial evaluating trientine versus depenicillamine, and the aim of the study was to evaluate the efficacy and safety of trientine compound, trientine tetrahydrochloride, to treat clinically stable adult Wilson disease patients who were on depenicillamine therapy. So compared to the continuation of depenicillamine, the treatment with trientine was tolerated and was found to be non-inferior to the depenicillamine in terms of efficacy as measured by this new assay, non-ceruloplasmin copper. Shown here on the left is the assay for non-ceruloplasmin copper over time during the study. This was the lead-in period of 12 weeks, And you can see at time of randomization, non-ceruloplasmin copper was equal and did not differ throughout the 24 weeks of the study, and even was not significantly different even through the extension phase, although interestingly, you do see a difference, a lowering slightly occurred during the study, probably due to better patient adherence to diet and to medication. Interestingly, if you compare this to what we typically look at in many patients, the urinary copper excretion, you can see that in D-penicillamine, which is well absorbed and comes out in the urine, you can see high copper excretion continued throughout, although it did tail off as you see the tailing off of the non-ceruloplasmin copper. In the tetrahydrochloride patients, urine copper excretion still remained robust and pretty even at approximately 300 micrograms per day in individuals, but it certainly was less than that seen for D-penicillamine, prompting us to think there may be a secondary mode of action in blocking gut absorption. Now, with respect to comparing urinary copper excretion to non-ceruloplasmin copper, we had originally expected pretty linear relationship, and indeed we did not really see that as well, and you find more of a scattering with some individuals very high. And interestingly, some of the non-ceruloplasmin copper was relatively lower than the range we might have expected, between 50 and 150 micrograms. So we wanted to look at our hypothesis of whether the NCC pool is comparable to normal individuals and treated patients, the corollary being that correct targets for NCC was that of healthy individuals, and also see whether NCC was a correct target for guiding adjustments in Wilson disease and whether it's the most predictive biomarker. In our study at the beginning, if you compare to healthy individuals, all the patients at baseline on D-penicillamine had very similar NCC values. At the end of the assay, as I pointed out before, there was a reduction in the non-ceruloplasmin copper, more likely a study effect that had occurred. And if you look at the elementograms and look at Wilson disease patients on the lower level, you'll see the albumin peak here and the ceruloplasmin peak are almost relatively even in the amount of copper, very different than that present in the normal individual, where the ceruloplasmin peak is typically much higher. Back to this picture again, urinary copper excretion, and you can see there were a number of individuals that were very low. And this surprised us and made us think, really, in these clinically stable patients without signs of copper deficiency, we had better rethink our relationships. So the lessons: this was the first study to use non-ceruloplasmin copper as a primary endpoint. We found it more reliable than urine copper excretion and raised several questions. Should it be the same as in healthy controls? What is the real proper range for stability? And what is the range for safety of the drug? There's a lot for us to study. So let's get back to our hypothesis. First, that the NCC pool was comparable between normal individuals and treated Wilson's patients. The answer is probably not. And we found a lower value in treated Wilson disease patients, making us really rethink our targets. And then we do need correlation with clinical biochemical parameters before we can say NCC is really the correct target for guiding adjustments, or we think this has great amount of promise. And similarly, we know that NCC to be predictive of Wilson disease in terms of its outcome really will have to be looked at perhaps at different phases of the disease and correlate the parameters for stability and non-progression. Thank you very much for your attention.
Thank you for letting me know. I just want to know if there are any questions in the chat. Do you have, I might as well give a question more technical. The methodology they're using for detecting the copper, does it specifically measure copper and no other ion, no other metal ion?
No, the actual copper measurements are made by ICP mass spec, and that does have the capability of multi-metal analysis. However, we were focused on the recovery of the copper and in each of the individual peaks of the separated proteins, and it was extraordinarily high and accurate and reproducible. which gave us confidence in using the assay. But you can look at other multiple elements. It's just a matter of choosing to do so in the methodology. The nice thing about ICP mass spec gives you a very good dynamic range of measurement. So often before, when atomic absorption was used in the past, you'd have to change lamps, or even with multi-detectors, you'd have to dilute samples into the range to be able to give a very accurate value, whereas in this technology, you can really get a very good measurement. And so if you choose to look at, for example, zinc or manganese or other metals, one could do so in the same specimen.
Yeah. And how available are these machines in hospitals or in clinical practice?
In clinical practice, not really. I think many of the major laboratories and often we talk about doing metal analysis in reference laboratories, because it's not just only doing the analysis, but making sure that it's done accurately and with the appropriate standards. It really is a challenge currently to do the proper standardization. And there's a couple of different methods. One could either use the, and not so much for the elements, those are very accurate, but to have the accurate amounts of a protein, such as ceruloplasmin. So sometimes you can use the sulfur and the protein ratios to the recovered copper, and other instances, you may actually use a standard, but then you have to know accurately that your standard contains the full complement of the copper atoms and that there's not degradation. And that has some challenges right now.
Thank you.
Mike, forgive my ignorance with this question, but I suppose the intention is to chelate the copper to reduce organ damage. Does the NCC, measured in, as you have with this methodology, in the periphery, is it important a correlate of brain damage as it might be of liver damage or red cell damage? Does this hold for any of the target organs that could be affected, broadly speaking, in Wilson's disease? Do you think that the NCC as your endpoint would hold equally for improving brain damage, liver damage in the broader sense?
No, that's a very important question, and something we do need to show in longitudinally in individuals during courses of treatment. But the one thing, we started in this study with already well-treated, stable patients. Most of them have been on therapies for a decade or so. So our question was a little different in comparison, but what we had hoped we would see, if there was any failure of the medication, which we didn't see amongst individuals, you would then note that this would sort of be the canary in the coal mine, that we would see the changes in this pool of copper prior to what we would see clinically. And that's how we can carry the study on for 24 weeks as a primary endpoint, because we may not see the clinical changes necessarily during that time period. So I think this is a real advance in being able to move that time frame closer to creating the ultimate predictability in the question you asked of, if you let this pool run amok, so to speak, then you will then see the deposition in tissue. We do know in animal models that, you know, this pool of copper does increase during damage to the liver, and over time in less well-treated patients, the parallel assay of the exchangeable copper also shows an expansion, and these pools are, while there may be differences in the assays, the pools are relatively looking at the same principle, that copper that's not bound to ceruloplasmin. So we hope that it brings our timeline closer to being able to look at changes faster and more accurately. And for my patients, they certainly would love if I give them a blood test and don't have to have them do the 24-hour urine collection. So that's just another, ease of working with patients.
Thank you very much. I suppose because we have an audience of generalists and hepatitis specialists, based on your vast experience, is trientine equal to D-penicillamine as a first-line treatment in newly diagnosed patients with Wilson's disease? Is that a broad principle that you would hold to now?
Well, we have used trientine, although yeah, I have to state very clearly it is an off-label use technically to use it as first-line therapy because those studies haven't been formally conducted, and it is approved typically previously to this study for people who were D-penicillamine intolerant. However, this now shows that even the D-penicillamine tolerant patients can be switched to the trientine without any ill effect. So the answer is still, we still need to have these studies formally done, but a number of people in this field have used the trientine for years as first-line therapy when we were able to do so, with advising our patients that it may not be on label particularly, but also with very careful monitoring, because we think it has a very good safety profile.
Thank you.
Okay, I think we can wrap up this session. Again, thank you very much, Mike, for the presentation and for answering all our questions. I appreciate it.
Thank you.
Thank you very much. So our third and final speaker in the session is Christoph Ezodi. And actually, Christoph doesn't need an introduction to this audience, but he is currently a Senior Director, Global Medical Affairs, a liver disease in Gilead Sciences, but we will all recognize his name from his contributions to the literature in the development of antiviral agents for hepatitis C, as well as hepatitis B. And he's going to give us a broad overview of a Gilead contribution in liver disease. Thank you very much, Christoph.
Good afternoon, everyone. I am Christoph Ezodi from Gilead Liver Disease Global Medical Team, and it's a pleasure to present the Gilead commitment to patients with liver disease. When we zoom in on the liver disease portfolio, it shows Gilead long-standing experience. Gilead started its journey in liver disease in hepatitis B. We have long-standing legacy, but we remain committed to improve the clinical profile and outcomes of patients with HBV. For HCV, we are proud that we are able to contribute to simplifying the care cascade for patients with HCV by bringing pangenotypic drugs to the market and help support the journey towards HCV elimination. Recently, hepatitis Delta was added to our portfolio, and here our goal is to address the unmet needs for those living with this most severe form of viral hepatitis. Finally, apart from viral hepatitis, we have made a commitment to help find solutions for patients with NASH. We feel honored to be able to support some of the great research ideas from clinicians and researchers like yourself. This map shows the large reach of our investigator-sponsored research programs. We currently support over 210 local research projects in 56 countries. Globally, we focus on HCV elimination, HBV, and hepatitis Delta. As you can see on this slide, Gilead has been a leader in viral hepatitis. Due to 30 years of innovation, 8 drugs were launched, aspiring to transform the lives of 366 million patients. Based on clinical trials and real-life experience publication, sofosbuvir and velpatasvir for 12 weeks allows to cure most of the HCV patients regardless of the genotype and severity of the disease, including the sickest patients. The MINMON study, recently published, amplifies the potential for sofosbuvir and velpatasvir for 12 weeks to be used as a minimal monitoring approach to hepatitis C treatment in a diverse patients population. As you know, HCV patient activation and innovation are our priority, and we support the FIND-C program, whose aims are to reduce the burden associated with screening for HIV by using machine learning algorithms to identify patients who are highly likely to be positive but undiagnosed, and to meaningfully reduce the screening rate, meaning reduce the number of patients who need to be screened for each correctly diagnosed HCV patients. Gilead provides also transformative medicine improving HBV care. It's important to note that the absence of resistance observed with these drugs, whose administration for 5 years has demonstrated reversal of fibrosis and cirrhosis in the majority of patients. Finally, these drugs clearly prevent the HCC occurrence, and the benefit of HBV early treatment will be discussed during our PHC symposium. Now, the main goal of Gilead's HBV cure program is to identify finite duration combination treatment regimen to achieve durable, significant HBs antigen loss rates in specific HBV patient populations. Currently, Gilead is investigating several therapeutic strategies to make HBV cure a reality. Our current pipeline is supported by a strong scientific rationale. In addition, Gilead is partnering with the scientific community to explore if, how, in whom, and when these new approaches can be optimized both alone or in combination with other agents. Gilead's commitment is also addressing unmet medical needs. Recently, HDV was added to our portfolio. The prevalence of Delta antibodies among HBV patients is highly variable, probably around 5%. HDV co-infection is more aggressive than HBV monoinfections, meaning more cirrhosis, decompensation, HCC, and liver-related deaths. And persistence of HDV DNA is associated with a worse outcome. Bulevirtide, an entry inhibitor, is the first-in-class treatment for HDV conditionally approved by the European Medicines Agency for the treatment of all chronic HDV adults with compensated liver disease. Bulevirtide monotherapy in clinical trials, but also in real-life cohorts, is efficient and well-tolerated in HCV patients. And bulevirtide monotherapy is a reference therapy for those patients. Gilead forged ahead with the research collaboration with Novo Nordisk in NASH. Following phase 2A study encouraging data, a phase 2B combination study including semaglutide, firsocostat, and or cilofexor is ongoing for treatment of patients with the highest need of care, patients with NASH and compensated cirrhosis. To conclude, Gilead is committed to transforming the management of liver disease through innovative medicines, collaboration with the liver community, and unparalleled commitment to patients. Together, we can continue to create possible for all patients with liver diseases. Thank you very much for your attention.
Christophe, thank you very much for that overview and for keeping us up to date with aspects of Gilead's ongoing contribution. Please post your questions to Christophe in the question section. We'll pick them up. Perhaps I could ask the first question to Christoph and put you on the spot a little bit. I think it's generally recognized for, particularly for chronic hepatitis B in resource-limited countries, that antiviral treatment and the cost of generic antiviral treatment is not generally the barrier now to reaching elimination targets. It's much more about finding patients, and you showed us a slide on FIND-C, and linking those patients, as well as refining and simplifying indications for treatment for chronic hepatitis B. So are Gilead hands-off in this process now that you've handed over tenofovir to generic companies? What's Gilead's commitment, for example, in sub-Saharan Africa, to processes of finding patients, linking them to care, and linking up with diagnostic companies to get measurements of Hep B DNA? And then the rest is simple, a pill a day for quite effective treatment of chronic hepatitis B that limits morbidity. So perhaps I could put you on the spot with that, Christoph.
No, thank you very much, Jeff, for this excellent and very important questions. As you mentioned, patient activation is very important for HCV, HBV, also HDV, and for all countries, including Africa. So yeah, so we have this FIND-C program. This FIND-C program could be duplicate in FIND-B and also in FIND-D, and we are working on that, and we have a lot of cooperation and collaboration with different groups. So at the beginning, it will be more focused on developed countries, but at the end of the day, probably we can use this type of tool for other countries. Another very important program is our Rolling C program, meaning to activate diagnosed patients but untreated patients. And we know that we have, again, in developed countries, but also in other countries, many diagnosed patients for HBV, HCV, HDV, but untreated. So we support a lot of program for Hep C, and in the near future for Hep B, and also for hepatitis delta. And as a simplification of HBV indication, and we support a lot of studies showing that early treatment could be appropriate for all HBV patients. So to conclude, currently we try to activate patients to have the FIND-C, the FIND-C BD program, Rolling C BD program, and to try to simplify patient indication, patient monitoring for all viral hepatitis. It's not available currently, but we can think that in the near future it could be used by different countries, but also by the other countries.
Can I ask you and Raymond a question? The field of hepatitis B cure remains on fire, but these are very expensive developments compared to very inexpensive nucleoside analogs. Can I just ask Raymond, who's got his hand raised to ask a question, and yourself, how should we view the field at the moment of cures which are tantalizing versus very inexpensive nucleoside analog maintenance suppressive therapies? Where are we headed?
Oh, yes. So it's a very important question. So currently, one of our strategies is to develop this HBV cure program. But as you mentioned, it's very expensive, and we will have some data and perhaps some drug available, but perhaps in 5 or 10 years. And in the other hand, we have this very important drug, very effective, and with a good safety profile, allowing viral suppression. But we know that probably HBV cure could be more appropriate. in the future, and that it's better to have a functional cure. But we don't know if it will be so easy to reach this point. So currently, we could have a lot of very good data, very good results with analogs. So analogs are really very important for HBV field.
Can I give Raymond the last word?
Yeah, sorry.
You're on mute, Raymond.
So the reality is that we don't have any treatments right now for hepatitis B that can cure. That's the limitation. We have great vaccines. So let's not talk too much about cure for hepatitis B. Everybody's talking about cure for HIV. We don't have the drugs yet. So that's what will come, but give it some more time. The vaccines are certainly available, and prevention is the way to go. But I think for HCV, I would like to turn quickly to HCV and ask maybe the last question, and it's provocative in a way. Have you ever tried, for example, the trials of Epclusa, say, with a protease inhibitor in order to shorten the treatment? I still think, I'm being greedy. 12 weeks is a long time to treat people globally to get elimination. It can work, of course. It has worked in Egypt and other places. But can we shorten the treatment with an addition of a protease inhibitor to Epclusa? Would you like to answer that, please?
It has to be a very brief answer. I'm sorry, we pressured.
No, really, I have no idea, and it's not planned currently to do this type of study.
But these type of studies could be done by the NIH, could be done by the French government. I think it's important, if we're going to eliminate globally, we have to work together. And that's what I'm trying to say. I think we got to work with the different intercompanies, and especially, I think there is an opportunity there to shorten treatment, and everybody will benefit, not only the companies, but also the patients.
Thank you very much. I regret that we have to close this brief session. Once again, I'd like to thank all of the speakers for their contributions. I'd like to thank my co-chair, Raymond Shinazi, and we'll see you again tomorrow for a second session on new pipelines. Thank you all.